Hey everybody! I hope everyone is having a great spring so far. It's great to be back with you again today, and today we're going to spend a little bit of time talking about anticoagulation. This is a really important topic for emergency physicians because we see patients with disruptions in their coagulation on a daily basis, whether that be a patient who is deliberately anticoagulated or a patient presenting with a thrombotic or thromboembolic problem. Now, in the last 3 years, the landscape of anticoagulation has changed dramatically. There's a whole host of new agents out there, both for anticoagulation and for reversal. Because these patients are ubiquitous in the ED, it's important for the ED doc to be familiar with these agents and how to manage them. This discussion is mainly going to focus on the new oral anticoagulant drugs that have become available in the last 2 to 3 years, and their advantages and disadvantages relative to warfarin, which is sort of the classic drug that we're all familiar with. We're also going to discuss PCC, or prothrombin complex concentrate, which is a reversal agent that has been available in Europe and other countries for years, but only recently became approved in the United States. And last of all, we'll just enjoy a little bit of creative artwork to keep things moving along. Now, before we really get into the discussion of the drugs themselves, let me toss out a couple of clinical scenarios just for you to keep in the back of your head during this whole discussion. Case 1 is a 63-year-old guy that came in with a swollen calf for about 3 days. Has an ultrasound that reveals a popliteal vein DVT that extends into the distal femoral vein. The guy is completely free of any chest pain or shortness of breath, and his vital signs are listed for you right there and look pretty stable. So, to dispo this guy, you'd like to start anticoagulation and send the patient home for follow-up. But what strategy will you use to anticoagulate this patient? Or how about this one? We've got a 58-year-old woman who comes to the ED with acute hematemesis, but she's on rivaroxaban. Her vital signs are listed right here for you, and you can see that she's a little tacky, maybe a little bit tachypnic, and her blood pressure's kind of marginal. Exam reveals coffee ground emesis that she's yakking up right in front of you, and her initial hemoglobin and hematocrit are 7.4 and 21.6. Obviously, this is someone whose anticoagulation we're going to reverse. But how are you going to address this? I mentioned we would be enjoying some creative works of art, but who would ever have thought that this was a thing? Folks are officially crazy because every year there are literally thousands of people who create works of peep art for submission to these contests, and some of them are just unbelievable how creative they are. Alright, let's just jump right into this. We all know about anticoagulants. They're widely used all over the world for prevention and treatment of venous thromboembolic disease, and in 2010, over 3 million prescriptions for warfarin were filled in the United States alone. The use of anticoagulants is rising because the population is increasingly becoming more elderly. The mechanism of an anticoagulation is pretty straightforward. You want to inhibit specific factors in the clotting cascade in order to disrupt it, hopefully in somewhat of a predictable fashion. Sorry about this, everybody, but it's time to talk about the dreaded clotting cascade. We all remember having to memorize this thing in medical school. It's not really important to know what every little detail of what activates what every step of the way is. What's really important to understand is the general concept that each factor activates the next one along the way, ultimately meeting in a common pathway that results in the activation of factor 2, which is thrombin. Once thrombin is activated, it converts fibrinogen to fibrin, ultimately leading to clot formation. There are lots of places along the way on this cascade where a disruption would prevent the cascade from being able to continue forward, and that's where the anticoagulants are typically targeted. When I think about anticoagulants, I kind of think of them in terms of the yin and yang principle. You're trying to reduce the risk of thrombotic or thromboembolic events, but at the same time you're using a drug that we all know increases the risk of bleeding complications. So these risks and benefits have to be assessed and balanced for each individual patient. Because what you're trying to achieve is ultimately what I kind of nicknamed the Goldilocks phenomenon. You want your patient to be right in that sweet spot where the blood's not too thick, it's not too thin, and you want it to be just right. So here's our first example of a little bit of peep art. Up until just a couple of years ago, warfarin has been the only oral anticoagulant that's available for us to use. Does it amaze anyone else that we're still using a drug that was originally developed to kill rats in the 1940s? It was approved as a medication in 1954 and inhibits production of the vitamin K-dependent clotting factors 2, 7, 9, and 10, and ultimately prevents the activation of factor 10 to factor 10A. The fact that it took us over 60 years to come up with something that is comparable or better than warfarin only goes to show you how hard this is to do. Just to help keep things a little bit visual, here's a quick peek at where warfarin actually affects the clotting cascade. One of the things that makes working with warfarin difficult is that it has a really long half-life. And the reason it's got a long half-life really depends on the elimination half-life of the vitamin K-dependent factors themselves. Factor 7 has a half-life of only 4 to 6 hours, so that one's pretty easy to work with. But look at factors 2, 9, and 10. Once you deactivate them, it'll take anywhere from 21 to 70 hours before these factors are actually back up and running in your system. Plus, because it takes such a long time for those to be eliminated, patients will require bridging with something like low molecular weight heparin because it takes such a long time to actually achieve this anticoagulant effect. This is also a real problem when you have to reverse a patient who's on warfarin. We were all taught that vitamin K is a reversal agent for warfarin, and it starts to work about 6 to 8 hours after you start the dose, but takes up to 3 days for full reversal to occur. The other major issue with warfarin is that it interacts with everything under the sun, including foods, drugs, you name it. There have been up to 740 drugs that have known interactions with warfarin, and almost 200 of them have been classified as major interactions. And this is a real problem because the people that are on warfarin tend to be people that are older, they're sicker, they need to be on things like antibiotics and antifungals more commonly, they have arthritis and so they're wanting to use things like NSAIDs, and it interacts with all sorts of homeopathic crap that our patients come in using all the time as well. In fact, out of all the thousands of different medications that are out there, warfarin is the leading cause of drug-related adverse events, with about 15 to 20% of patients per year having some sort of a bleeding complication, 1 to 3% of these being fatal or life-threatening. And lastly, there's that whole warfarin necrosis syndrome thing to talk about. It's fairly rare and occurs in less than 1 out of every 1,000 patients that are started on warfarin. But when you think about how many millions of patients are on this drug, that means it's relatively likely to be something that you're going to see at some point in the ED. It's typically associated with the initiation of therapy and is thought to be related to the procoagulant effect that occurs in that first 24 to 48 hours after the initiation of therapy. And bad things can happen as a result of the systemic thrombosis that can occur in the microvasculature, such as gangrene and limb necrosis. Based on all of the problems associated with warfarin, it's absolutely ludicrous to think that it would have a snowball's chance in hell of being approved by the FDA today. But up until recently, we just didn't have any other options. So by now, most of you have probably figured out that I freaking hate warfarin. It's a pain to start that drug because of the whole bridging nonsense. It's a pain in the butt to use because you have to monitor it by checking the INR all the time. And there are all sorts of complications associated with it. For a long time it was all we had, but fortunately, in the last 3 to 4 years, some new oral anticoagulants have finally been developed and released. Now, these are not without their own problems, but given all the problems associated with warfarin, I do think that these are worth a look and worth consideration. I will freely admit that my own bias is that you can't really get any worse than warfarin, so I might be a little bit more willing than most to go ahead and adopt something new. But the bottom line is that these drugs are out there, and so we need to know how to manage them. The first of the novel oral anticoagulants, which I'll probably just call NOACs from here out to keep it simple, was dabigatran. The trade name for this drug is Pradaxa, and this was approved in October of 2010. Initially, the only indication it had was stroke prevention in patients with non-valvular atrial fib, but recently the FDA did approve this for treatment of DVT and PE as well. However, in the second indication, they also require 5 days of parenteral therapy prior to the initiation of this treatment. Dabigatran is a direct inhibitor of thrombin and prevents the conversion of fibrinogen to fibrin. Here's a quick peek back at the clotting cascade just to illustrate where this drug works. As you can see, it works on the activated form of factor II, which most of us would just refer to as thrombin. This drug does have some promising features. Dabigatran has a much shorter half-life than warfarin, and after you take the first dose, you're fully anticoagulated within 2 hours of ingestion, so there's no bridging required with this drug. The other bonus is that the dosing is standardized, and the degree of anticoagulation is much more predictable, so no INR monitoring is needed. However, you do need to make sure that the patient has reasonably good renal function prior to the initiation of this drug. There are a few problems with this drug. It does have some important drug interactions, and I'd like to point out that a few of the major players in this list include amiodarone and verapamil. For a drug whose primary indication for the first several years it was out was the anticoagulation of patients with AFib, this seems kind of suboptimal. There are some contraindications to giving this drug, and most of them fall into the "thank you, Captain Obvious" category, such as allergy to the drug or active bleeding. Patients that have mechanical heart valves shouldn't be given this drug either, as the REALIGN trial showed that there were higher rates of complications among patients on Pradaxa than among patients who were on traditional anticoagulation, such as Lovenox or warfarin. There's also no information about how this performs in pregnant patients, and so it's category C for pregnancy. One of the biggest concerns about dabigatran is the fact that there isn't a specific reversal agent available. It does have a short half-life, about 12 to 17 hours long, and does wear off in about 24 hours. We also really don't know what's going to happen with this drug in the event of an overdose yet either, because there's no human data out on this yet. According to the package insert, charcoal might be effective, and dialysis may remove up to about half of the circulating drug, but currently we just don't have any human data on how it's actually going to affect the patient. So is dabigatran actually any better than warfarin? When it was studied, the rates of adverse events were pretty much comparable, and there were no statistically significant differences between the groups. There was a slight trend towards less bleeding overall with dabigatran, but again, this did not achieve statistical significance. So let's break this down with a quick pro-con discussion. On the pro side, we have a drug that doesn't have any need for INR monitoring, and you get fully anticoagulated within 2 hours of the first dose without any need for bridging. It has a less variable anticoagulant effect than warfarin, fewer drug interactions, and fewer dietary restrictions. But on the flip side, it's substantially more expensive, in the range of $4 a pill instead of about $6 a week. There's less experience with it because it is a new drug, and unfortunately it's probably not a good agent for patients that have renal failure. And of course, there isn't a specific reversal agent for this drug. The next of the novel oral anticoagulants that was approved was rivaroxaban, which was FDA approved in July of 2011 in the United States. When it was first released, its initial indications were primarily for DVT prophylaxis and for the treatment of non-valvular atrial fibrillation. However, within a year, it also received indications for the treatment of DVT and pulmonary embolism. Rivaroxaban is the first oral inhibitor of factor Xa. I think most of us are probably already familiar with working with agents that work on this factor because most of us have been using enoxaparin as a parenteral agent for a number of years, which also works on factor X. Here's another quick look back at the clotting cascade, just so you can see where factor Xa fits into the scheme of things. The half-life of rivaroxaban is pretty short, only 7 to 9 hours. When it's first started, it does require twice daily dosing for the first few weeks, but then maintenance therapy is only once daily. Full anticoagulation is achieved within 2 hours of taking the first dose, and so no bridging is required. Additionally, drug monitoring is also not required because it has very predictable pharmacokinetics. However, with this agent, you still need to check the patient's renal function prior to initiating their therapy. Fortunately, the drug interaction list is a little bit more forgiving with rivaroxaban. The primary offenders on this list are a couple of antibiotics, an antifungal, and mainly a couple of seizure medications. The contraindications are, again, more or less the same and include primarily allergy, active bleeding, and pregnancy, since there's no data available on this. There isn't a specific reversal agent available for rivaroxaban, but it has such a short half-life that the anticoagulant effect is basically gone in about 12 to 24 hours after the last dose. Overdose treatment is again sorta iffy because we just don't have any human data. This drug isn't effectively dialysable, but again, active charcoal might be effective. So how did rivaroxaban stack up against warfarin? When you looked at major bleeding events, including intracranial hemorrhage and life-threatening hemorrhage, there basically was no difference between the groups. So let's do our pros and cons for rivaroxaban versus warfarin. On the pro side, there's no need for INR monitoring and no need for bridging. There's a less variable anticoagulant effect than warfarin, with fewer drug interactions, no dietary restrictions, and the effect wears off in 12 to 24 hours. On the con side, it's substantially more expensive than warfarin, about $6 a pill as opposed to $6 a week. It's not for use in patients that have renal impairment, and while there's no specific reversal agent available, there is some literature suggesting that PCC might be effective, and we'll talk more about this later. Why'd you have to go and make me so constipated? 'Cause right now I'd do anything to just get my bowels evacuated. The next of the NOACs to be approved was apixaban, otherwise known as Eliquis. It was FDA approved in December of 2012, initially for non-valvular atrial fibrillation and DVT prophylaxis. It was subsequently given indications for the treatment of DVT and pulmonary embolism, as well as prophylaxis for recurrent DVT and PE. Apixaban is also a factor Xa inhibitor, very similar to rivaroxaban. This picture probably looks pretty familiar because apixaban works in exactly the same place on the clotting cascade as rivaroxaban and enoxaparin. The half-life of apixaban is about 12 hours, and again, full anticoagulation is achieved within 1 to 2 hours of taking the first dose orally. No bridging is required because it has such a rapid onset, and again, drug monitoring is also not required for this agent either. The major advantage of apixaban over the other two agents previously discussed is that this agent can still be used in patients that have some impairment in their renal function. The drug interactions for this medication are pretty much the same as those for rivaroxaban, primarily including a few antibiotics and some antiepileptics. The contraindications are also fairly obvious as well, mainly allergy and active bleeding. Like all of the newer agents, there is not currently a specific reversal agent available. However, the half-life of this drug is relatively short, and the anticoagulant effect is gone within 12 to 24 hours. It's typically recommended that this drug be discontinued about 24 hours prior to any planned surgical procedures. There is very limited data regarding what to do after an overdose, but there is some data that in healthy subjects, administration of activated charcoal at 2 and 6 hours after ingestion of a 20 milligram dose of apixaban reduced the absorption by up to 50%. So how did apixaban stack up against warfarin? In this trial, major bleeding was defined as clinically overt bleeding that was accompanied by one or more of the following: a decrease in hemoglobin of more than 2 grams per deciliter, a transfusion of 2 units of packed red blood cells or more, or bleeding that occurred in one of the following critical sites, including intracranial, intraspinal, intraocular, pericardial, intraarticular, intramuscular with compartment syndrome, retroperitoneal, or bleeding that was ultimately fatal. When the rates of major bleeding events between the two groups were compared, there was a trend towards less bleeding with apixaban, however it didn't quite reach statistical significance.
Minimum wage! Yeah!
Just a couple of months ago, the FDA approved yet another factor Xa inhibitor, and so there's another new kid on the block. Edoxaban was approved in January of this year and was given indications for the treatment of non-valvular atrial fibrillation as well as for treatment of deep vein thrombosis and pulmonary embolism. However, it's only approved for initiation of therapy after 5 days of a parenteral agent. So this is yet another factor Xa inhibitor, and honestly, I'm not quite sure what the thought process was in approving this one when there's already 2 other oral Xa inhibitors on the market. I promise, this is the last time we're going to look at the clotting cascade during this discussion. And as you can see, this drug also acts on factor Xa in exactly the same position in the clotting cascade as rivaroxaban and apixaban. There really isn't anything else that's new or different or particularly interesting about this particular agent, so I'm not going to spend any more time talking about it, because ultimately this is just another Me Too drug. Now, if you'll indulge me for just a minute, we'll take a little break from the data, and I'm just going to go ahead and give you my opinion. And I'll preface this by saying that it absolutely is just my opinion. But if I had to predict what's going to happen with the novel oral anticoagulants, here's my guess. I think that rivaroxaban and apixaban are going to become the major players. They're easy to work with, they're easy to dose, and they're approved for all of the major indications with the exception of mechanical valves. They don't require any parenteral bridging agents like the other two do, and apixaban can be used in patients with some diminished renal function as well. The Xa inhibitors also work a little bit higher up in the clotting cascade than dabigatran, and so they're more likely to be easily reversible with some of the therapies we already have available, and we'll talk more about reversal in a few minutes. I think it's a lot less likely that we'll be starting dabigatran or edoxaban in the ED, if for no other reason that their indications still require 5 days of bridging with a parenteral agent, which is inconvenient for our population. That being said, it's still important for us to recognize that these drugs are anticoagulants so that we recognize it when our patients come in taking these agents. Alright guys, you have made it through the painful part of this presentation where we just had to talk about the drugs themselves. Now let's talk about how this affects us in the ED. I think the most important thing is just knowing that these drugs are out there and recognizing that these are anticoagulants. But the management of thromboembolic disease is really changing. In the most recent guidelines regarding the management of thromboembolic disease published by the American College of Chest Physicians in 2012, outpatient management of DVT is actually preferred over inpatient management unless the patient has other complications necessitating inpatient treatment. The other big one is that outpatient management of pulmonary embolism is going to be coming to an ED near you. Outpatient management of PE might completely blow some people's minds, but it's probably going to become the standard of care in the next set of guidelines. In fact, the 2014 European Society of Cardiology guidelines that are endorsed by the European Respiratory Society has included this as a reasonable and viable treatment option for low-risk PE patients. They recommend use of one of the validated screening tools to determine who is low risk enough to treat at home, and there are a number of different studies, including a meta-analysis published in 2013, that support this practice. The availability of the novel oral anticoagulants does probably make our lives a lot easier when it comes to actually managing and discharging patients from the ED with thromboembolic disease, because patients are a lot more likely to take a pill than they are to want to give themselves subcutaneous injections and then go to all these follow-up appointments for INR monitoring. In December of 2010, the Einstein investigators published a trial in the New England Journal that demonstrated the non-inferiority of rivaroxaban versus warfarin, with an adverse event rate of 2.1% with rivaroxaban versus 3% with warfarin. In July 2013, the Amplify investigators found similar results in a trial of apixaban versus warfarin that showed equivalent efficacy and a slightly reduced incidence of bleeding, although the decrease in bleeding was not demonstrated in the follow-up Amplify trial. And these are the trials that ultimately led to the approval of these drugs for the treatment of thromboembolic disease. And come on, guys, let's face it, we're never going to have an anticoagulant that doesn't result in an increased risk of bleeding, because patients that are anticoagulated are going to be more likely to bleed no matter what the drug is. Now, before you all panic, I'm not going to go over each of these trials in detail. If you're interested, feel free to pause this presentation and you can look at each of these trials individually. I think that the majority of us are already managing most of our DVT patients as outpatients. So let's take a couple minutes and just talk about the management of pulmonary embolism as an outpatient. One thing that a lot of people have told me in the past is that when managing patients with DVT as an outpatient, they feel obligated to perform a CT of the chest to rule out pulmonary embolism before discharging the patient home. But since low-risk PE patients can be safely managed as outpatients, I'd like to pose the question to you: if the patient is hemodynamically stable, not hypoxic, and doesn't have any chest symptoms, does it really matter if the patient has a PE if they're asymptomatic? Because they're going to be anticoagulated for their DVT anyway. So let's talk about some data. Here's a meta-analysis of 15 trials that included about 2,300 patients that were treated for a pulmonary embolism. Only randomized controlled trials or cohort studies that included patients with acute, symptomatic, and objectively proven PE were included. And to be eligible, at least part of the study population had to either be treated with anticoagulants at home or had to have been discharged early. All of the patients that were included were low-risk patients, as moderate and high-risk patients were all admitted. Based on historical data, low-risk patients with PE that are treated in the hospital have a low risk for fatal recurrent PE within the first 3 months, with a rate of about 0.4%. They have about a 3% risk of non-fatal recurrent PE, and fatal major bleeding occurs in 0.2% of patients within 3 months after pulmonary embolism, with a non-fatal major bleeding rate of about 2%. Before outpatient treatment in low-risk PE patients can be accepted as a standard for patient care, comparable safety to inpatient care has to be proven. The data from this meta-analysis showed that the rates of recurrent venous thromboembolism and major bleeding were essentially identical whether the patient was treated as an inpatient, discharged early, or treated as an outpatient. And none of the patients in any of these cohorts actually died as a result of their pulmonary embolism. All-cause mortality was higher in the outpatient and the early discharge groups. However, when you looked at the patients included, this group had a much higher incidence of patients that had malignancy. After excluding the studies with an overrepresentation of patients managed as outpatients that had malignancy, the pooled incidence of mortality in outpatients decreased to 0.6%. Based on this data, there appears to be no increase in risk when managing low-risk patients with PE as outpatients. So, how do you figure out which of your patients with pulmonary embolism is low risk? There are several risk stratification tools that have been developed to help identify which patients are low risk for outpatient management. The most common is the PESI score, which looks at 11 variables and can help you predict the patient's 30-day mortality. This is useful for selecting potential candidates for outpatient treatment, but can also help you select which patients are high risk and which ones may benefit most from thrombolytic therapy for PE as well. This score has been validated externally in over 17,000 patients to date. And don't panic, there's an app for that, so you don't have to memorize this stuff. In fact, there are several apps. The one above is just called PESI. I also have it on ERRes, I have it on MedCalc, and it's free and online at MedCalc and at least a few other websites as well. There's also some data coming out that says that maybe we don't need to use something quite this complicated. In 2010, the Archives of Internal Medicine published a simplified version of the PESI score. You're given 1 point for any of these high-risk variables, and the scoring is really easy. If you're 0, you're low risk. If your score is 1 or higher, you're automatically high risk. Univariate analysis showed that the original PESI variables of sex, respiratory rate, temperature, and altered mental status really were not significantly associated with 30-day mortality. These variables were therefore not included in the simplified PESI score. So how'd it do? The results using the PESI score versus the simplified PESI were very similar, and it appears that the sensitivity and the negative predictive values were really good, possibly even better than the original PESI score. However, they used a retrospective cohort for their validation set, so this still needs to be prospectively validated on a population before it's ready for prime time, but I expect that we'll probably hear more about this pretty soon. Now that we've spent some time talking about all the new ways you can thin the blood, let's talk about what's new in reversal. When we consider what the potential barriers are to moving to the new oral anticoagulants, the most commonly cited barrier that you hear from physicians is that the new agents aren't reversible. I'm just going to go ahead and go there because I think that's a really stupid argument, and here's why I think it's a stupid argument. All of us have been using a non-reversible anticoagulant for more than a decade. So if you've ever given a patient a dose of enoxaparin, otherwise known as Lovenox, then you've given someone a non-reversible anticoagulant. Protamine really doesn't work to reverse this, but despite the fact that there isn't a reversal agent for it, no one ever bats an eye about giving a dose of enoxaparin. And besides which, I'd like to point out that up until about a year ago, when the PCCs were approved in the United States, Coumadin wasn't exactly reversible in a way that was clinically meaningful. We all know that vitamin K takes up to 48 hours to achieve full reversal, and at minimum, you won't see any effect for at least 6 hours after the dose, no matter what route you give it. To me, a reversal agent is something that should work rapidly, particularly if you have a patient with life-threatening bleeding, and to me, vitamin K just doesn't make the cut. It's still important to give it to these patients, but I can't say that I really think of it as a reversal agent. Now, on top of giving vitamin K, we also had to give patients fresh frozen plasma, and adding the FFP helps, but at best, you can only get the patient's INR down to about 1.6 to 2, because that's the INR of the FFP itself. So you really couldn't ever get your patient fully reversed. The other difficulty with FFP is the sheer volume that you need to infuse, usually between 4 and 8 units in order to adequately reverse your patient. And it takes a long time for that amount of fluid to infuse. Add that to the fact that it has to be thawed before you can even give it to the patient, and you're easily looking at 2, 3, maybe even 4 hours before you can have your patient reversed. The combination of these two agents will eventually get the job done, but the important question here isn't whether you can get the INR down, it's whether the patient stops bleeding and whether it actually improves their outcomes. Whether correcting the patient's INR actually stops the bleeding seems like a question that we would know the answer to, but surprisingly, we honestly don't really know if reversal makes that much of a difference. Does reversal really matter, or is the damage already done? This is unclear and probably depends mainly on where the bleeding is. I think intracranial hemorrhage is the one most of us are really thinking about when we answer this question, because even small amounts of bleeding can be devastating. So in these patients, is reversal academic, or does it really work? We don't know because there really hasn't been, and probably won't ever be, a study of anticoagulated patients where only one group gets reversal. But the question is whether or not the damage is already irreversible by the time the patient presents for care. Patients with intracranial hemorrhage have a much higher mortality than non-anticoagulated patients. Now that PCCs are available, there are some limited data to suggest that by reversing the patient's anticoagulation, we can reduce the size of the intracranial hemorrhage in these patients, but we don't really have any meaningful data on any patient-centered outcomes, like neurologic outcome and long-term mortality. Reducing the size of the patient's hemorrhage sounds like a good thing, and it makes logical sense that a smaller hemorrhage would cause less damage, right? This paper suggests that size really does matter. It looked at outcomes of patients with intracranial hemorrhages and found that in their very small sample of 200 patients, 28 of whom were anticoagulated, that the size of the bleed was really what mattered in this patient's prognosis, regardless of their anticoagulation status. So if we all agree that reducing the size of the hemorrhage is a good thing, and reversing the patient helps us to reduce the size of that hemorrhage, the question then becomes, does how quickly you reverse the patient make a difference? The majority of the literature published to date looks at surrogate markers, like time to achieving an INR less than some predetermined level, to determine the outcomes of the reversal of anticoagulation, rather than looking at any patient-centered outcomes. This review paper was published in 2009 and looked at the literature to date regarding the use of PCCs versus FFP for reversal of anticoagulation, and there were only a couple of small trials that actually looked at patient outcomes rather than just laboratory values. In the Fredrickson paper, they had 17 patients in the study that received 3-factor PCC versus FFP for an intracranial hemorrhage related to a vitamin K antagonist overdose. The INR reversal was much more rapid in the group that got PCC, and there was less neurologic deterioration in this group in the short term, but they didn't have any long-term outcome data to know whether that actually translated into better long-term outcomes. The next paper was a retrospective review of 55 anticoagulated patients that had intracranial hemorrhage, and they looked at 3 groups: vitamin K plus PCC, vitamin K plus FFP, and vitamin K only. And as you can see, the vitamin K and PCC group had much more rapid reversal of their INRs. They also had a significant decrease in hematoma growth in patients that got PCC, but unfortunately this did not translate into better outcomes in the long term. But then here's another paper that suggests that maybe rapid reversal does help. The data in this paper are a little murky, and because this was an observational trial rather than a randomized controlled trial, there really wasn't any standardization of the PCC regimen, and that makes the results really difficult to interpret. Only 41% of the patients included in the trial actually got the treatment recommended in the guideline, and the rest kind of fell somewhere in between. Only 3% of the patients in the study got FFP instead of PCC, and only 2 of those had intracranial hemorrhage, so it's not like the groups looked alike either. It sounds promising because the multivariate analysis in this trial showed a 2-fold decrease in 7-day mortality in patients that got PCC. It sounds great, but they only followed these patients out to 7 days, and all the data was retrospective. I would be a little bit more convinced if we had some prospective data and if we had groups that actually looked something like each other. So the bottom line here is that despite all this gnashing of teeth and wringing of hands, we can't really prove that reversing a patient's anticoagulation actually makes a difference long term. Now that we have completely exhausted the question of whether reversal matters, let's talk about how we do it. You basically have 3 options on how you can give vitamin K: in the mouth, in the vein, or under the skin. The current guidelines state that the subcutaneous route is so 20th century, and it's not a currently recommended route of administration. The subcutaneous absorption is erratic, and PO dosing is faster and it's more reliable. The current ACCP guidelines, which is basically the Bible when it comes to reversal of anticoagulation, says that for the non-bleeding patient or the patient with just mild bleeding, just give it PO. If you have a patient that has severe or potentially life-threatening bleeding, give it IV. And don't bother with the sub-Q route with any of these patients. So, who's seen a patient that got sent to the ED for a high INR before? The patient's not bleeding at all. In fact, the patient feels great, but their provider had a panic attack because their INR was 7 and sent a totally asymptomatic patient to the ED. What are we supposed to do with these people? Well, fortunately, there's a guideline for that, and it was actually updated in the 2012 edition. Based on the references used to develop the guideline, the risk of major bleeding really starts to increase after your INR hits about 4.5 or higher. Studies also show that giving vitamin K to this group overcorrects their INR, which is the basis of the change in the current guidelines. So if the patient isn't bleeding and has a safe home situation, they can just go home and have their INR rechecked in a couple of days as long as their INR is less than 10. For patients with an INR greater than 10, you'll give them a little bit of PO vitamin K, and then it really just kind of comes down to your clinical judgment to decide whether the patient's safe to go home or not. If your patient has minor bleeding, you're still going to treat them with oral vitamin K, but if you have a patient that has severe or life-threatening bleeding, do not pass go and do not collect $200. Just stop their warfarin and give them 10 milligrams of vitamin K slow IV infusion. Just be aware that although they are rare, anaphylactoid reactions do occur with IV vitamin K. So how much difference does it really make? Giving the vitamin K IV does seem to lower the INR slightly faster at 6 and 12 hours, but by 24 hours, the PO group catches up to the IV folks, and there don't seem to be any significant differences in INR at that point. In this paper from JAMA Internal Medicine, or the journal formerly known as the Archives of Internal Medicine, 66 episodes of excessive anticoagulation were studied. In patients with a baseline INR between 6 and 10, the response to IV vitamin K was more rapid than in the oral group, and the proportion of patients that reached a therapeutic range INR at 6 hours and at 12 hours was significantly higher. However, by 24 hours, there was no statistically significant difference between either of the groups, but the patients in the IV group did tend to be more often overcorrected. So let's talk FFP. It definitely has some advantages. It contains all of the blood clotting factors, but the INR of stored FFP hangs out right around 1.6-ish, and you can't correct somebody's INR below the level of the INR of the FFP that you're giving. 1 unit of FFP, which is about 250 cc's, corrects the patient's clotting factor deficit by about 2.5 to 5%. FFP does have the advantage that it's pretty readily available in most centers, and it's still the product of choice in most massive transfusion protocols, which makes perfect sense because it's a great volume expander too. Typically, a patient will be given 10 to 20 cc's per kilo as the initial dose of FFP. If you're wondering why that 4 units of FFP is kind of the universal starting dose, in order to have a significant change on clotting status, you need to get about a 10% increase in the patient's clotting factor levels. Taking the low end of 2.5% correction per unit of FFP, that gives you 4 units to get to 10%. Despite its advantages, FFP also has some pretty significant disadvantages. Number 1 being the amount of fluid you have to administer to your patient in order to adequately get reversal. This is particularly problematic in someone like, a CHF patient who's on Coumadin for atrial fibrillation. If it takes a minimum of 4 units and usually closer to 6 to 8 to reverse your patient, you're talking about a minimum of an additional 1 liter of fluid that you have to give that patient. And you probably can't just blow it in unless you want your patient to go into severe pulmonary edema. Unfortunately, this stuff also has to be typed and thawed, so there's typically a 30 to 60 minute delay at minimum before you can actually get it into your patient. Because it's a blood product, transfusion reactions can occur, the most serious being TRALI, or transfusion-associated acute lung injury. And while the risk of infection is really rare these days, it's not zero. The new kid on the block are the PCCs, or the prothrombin complex concentrates. Or rather, they're relatively new in the US, but they've been used in Europe and in Canada for years. They're available in either 3 or 4 factor concentrates, with the 3 factor concentrates including 2, 9, and 10, and the 4 factor concentrates also include factor 7. The factor concentration in this stuff is about 25 times that of plasma, and they also contain a little bit of protein S, a little bit of protein C, and just a little bit of antithrombin 3. Each vial has a tiny amount of heparin in it as well, so just an FYI in case you have a patient that has a known history of HIT. These are available as lyophilized powders, so they can be reconstituted and administered very rapidly at the bedside. It's not terribly common, but there's also a product called activated PCC, or FIBA, which stands for Factor VIII Inhibitor Bypassing Activity. It's similar to the other PCC products in that it contains non-activated factors 2, 9, and 10, but it also contains activated factor 7, so I kind of think of it like a 3-factor PCC with a little bit of Novo 7 sprinkled on in. Its indications are for spontaneous bleeding in hemophilia and surgical hemorrhage in hemophiliacs, but it has been used off-label somewhat for the reversal of warfarin and rivaroxaban. When we compare all the different flavors of factor concentrates that are available to us currently, the one that makes the most sense to me to use is the 4-factor PCC, because it's the most complete and costs less than the combination of a 3-factor PCC plus plasma or using the activated PCC alone. I'm not suggesting that any of this stuff isn't pricey, all of these are expensive, but the only patients who are going to get this stuff in the first place are the ones who are having life-threatening bleeding, and these patients are already getting admitted to the ICU and getting the million-dollar workup anyway, so I don't really see that as a barrier. So does PCC work? It sure makes the numbers look pretty. In this paper, they took 46 patients that were on vitamin K antagonists that had intracranial hemorrhages, and all of them were given reversal therapy with PCC. All the patients got the recommended dose of PCC plus 10 milligrams of IV vitamin K. The median INR in this patient population was 3.5 prior to reversal, and 30 minutes after the initial PCC dose was given, 89% of the patients had achieved an INR of less than 1.5. There were a few patients that required a repeat dose for full reversal, but the majority of those had an INR substantially higher than the median of 3.5. The effects of PCC were maintained in this population at 96 hours post-infusion in the majority of patients with no repeat doses given. The problem is that we don't really know whether making the numbers look pretty really is going to have much of an impact on patient outcomes because the literature is so mixed. Since the clotting studies are the best surrogate marker we have, it seems logical that fixing the numbers would help. But because of the ethics involved, I don't really think we're going to be seeing a study of reversal versus no reversal anytime soon. When you look at it graphically, it's clear that PCC is the way to go if you want rapid reversal. And this is why, in their most recent guideline update in 2012, the American College of Chest Physicians actually lists PCC as first-line agent for reversal over FFP. Fortunately, figuring out how to dose this stuff is relatively straightforward. It's based on the patient's pre-treatment INR and the patient's body weight. 4-factor PCC is dosed based on the amount of factor 9 per vial, and there's about 500 units per vial. So let's say we had a dude who weighs about 70 kilos and his INR is 5. We would take 70 kilograms times 35 units per kilo, because that's how much PCC you want to reverse someone with an INR between 4 and 6, and that gives us about 2450 units of PCC, so we'll just round up and give him 5 vials. Let's just summarize by running through our pros and cons really quick. The advantages of PCC is that it's faster than FFP, smaller volume of infusion, it's easy to give, you don't have to wait for it to be thawed, you don't have to wait for it to be matched, and there's no risk of infection. On the flip side, this stuff is expensive, and unfortunately, if the only PCC you have in your shop is 3-factor, you still have to give some FFP or some factor 7 to round it out. Thrombotic complications are rare with PCC, but they do happen. But the only patients that you're actually going to be giving PCC to are the ones that are already sick as snot because they have life-threatening bleeding. So what caused the clot? The PCC or their underlying illness? Nobody knows. So this paper is an actual head-to-head throwdown between FFP and PCC in the form of a multi-center, open-label, non-inferiority trial. They enrolled just over 200 patients that were randomized to 4-factor PCC or plasma, and the median baseline INRs between the two groups were basically the same, and if anything, the plasma group had a slight advantage. Effective hemostasis was achieved in about 72% of the patients that got PCC and about 65% of the patients that got plasma. However, one of their endpoints was how many patients got their INR corrected to less than 1.3 within 30 minutes, and 62% of the PCC patients got there within 30 minutes, whereas less than 10% of the patients getting plasma got there. The safety profile was pretty much the same between FFP and PCC as well. The big question on everybody's minds is, of course, does PCC work for the novel oral anticoagulants? The difficulty is that these agents are all so new that there's very little data out there. Using PCCs for the reversal of the novel oral anticoagulants is mechanistically a little bit different from using these to reverse the effects of vitamin K antagonists. In a patient who's taking something like warfarin, all you really need to do is replete the factor that's been deactivated. However, with the novel oral anticoagulants, what you're effectively trying to do is However, in the case of the novel oral anticoagulants, what you're actually trying to do is overcome or bypass the effect of the inhibitor by raising the levels of these factors to supernormal levels. In this paper, they looked at guys that were anticoagulated on dabigatran as well as patients that were anticoagulated on rivaroxaban, and then they gave them PCC to see what would happen. The patients that were given dabigatran and anticoagulated were noted to have an elevated PTT and thrombin time, and then they were given a 50 IU per kilo dose of PCC, and it had absolutely no effect on their clotting numbers. They didn't actually bleed the patients to see if they would bleed more. They also gave PCC to patients that were anticoagulated with rivaroxaban and found that they had complete normalization of the clotting studies almost immediately upon giving the PCC. So this data suggests that it probably actually works pretty well for rivaroxaban, but maybe not so well for dabigatran, probably due to the fact that dabigatran works a little bit further down in the clotting cascade. Here's another paper, which is a review article that looked at several small studies that used PCCs to reverse the effects of rivaroxaban and dabigatran. These papers all used a 4-factor PCC called Beriplex that is available in Europe, and the same product is marketed here in the United States as a product called Kcentra. Their data were somewhat promising, as their 4-factor PCC was shown to decrease bleeding time and prevent hematoma growth induced by both dabigatran and rivaroxaban. However, the evidence isn't really robust. Most of the data currently comes from animal studies, and what little human data we have comes from healthy volunteers rather than patients with ongoing bleeding, so there's still a relative paucity of human data. So far, the PCCs do show promise for being able to reverse the anticoagulant effects of the novel oral anticoagulants. However, it's hard to measure this effect because conventional assays that we're used to using, like the PT and PTT, really don't correlate well with bleeding or reversal of patients that are on the novel oral anticoagulants. It's also possible using PCCs to sort of overshoot and enhance parameters of thrombin generation to supernormal levels. There are some data in the literature to suggest that patients that have been treated with PCC are at higher risk for thrombosis after this treatment. But what we don't know is whether or not they were more likely to have thrombosis because they got PCC or because of their underlying illness that led them to need PCC in the first place. Furthermore, the dose and the effectiveness of a strategy for the reversal of the novel oral anticoagulants probably depends somewhat on the level of the anticoagulant present and which one it is. The bottom line here is we still don't know exactly how this is going to play out. What we really need are some good human data that looks at how effective PCCs are when used to reverse the novel oral anticoagulants. For now, if you have a patient that comes in on a novel oral anticoagulant who needs to be reversed, I suggest these 5 steps. Number 1, discontinue the drug. Try to identify where the patient is bleeding from, and if it's possible, perform local source control. If your patient is hypotensive or hypovolemic due to blood loss, go ahead and replace their blood volume if it's needed. And for patients who are having life-threatening bleeding, consider the addition of the PCC agents. There is some cool stuff on the horizon for reversal of the novel oral anticoagulant agents. Andexanet alpha is currently a compound that's being studied as a factor Xa inhibitor antidote. The cool thing about it is that it's in development as a reversal agent that would actually work for all the different factor Xa inhibitors. This stuff is basically a modified factor Xa molecule that competitively inhibits at the binding site for the anticoagulant drugs. In phase 2 trials, it rapidly reversed the effects of apixaban, rivaroxaban, and enoxaparin in healthy volunteers. And they also found that administration of the antidote alone was not associated with any procoagulant activity. This stuff is currently in phase 3 trials, so I'm hopeful that sometime in the next couple of years, if this pans out, that we'll actually have a reversal agent for the factor Xa inhibitors. This is just a little cartoon that kind of explains the mechanism of andexanet alpha and how it works to competitively inhibit at the binding site for the novel oral anticoagulants and for things like enoxaparin and fondaparinux. Pictures are good, right?
My master made me this collar. He is a good and smart master, and he made me this collar so that I may talk. Squirrel!
I know we've been at this for a while now, but let's go ahead and just think back to those two cases we had right at the very beginning of this talk. So clinical case 1 was the 63-year-old guy that came in with a swollen calf for 3 days and had a little popliteal DVT. You'd like to start the patient on anticoagulation and send him home for follow-up. This patient was found to have normal renal function, and ultimately you decided to start him on apixaban 10 milligrams PO BID, and he was discharged home and did well. Our second case was a little bit more challenging and was the 58-year-old woman on rivaroxaban that came in with acute hematemesis. You decided that the patient's anticoagulation needed to be reversed, and so the patient's rivaroxaban was discontinued. The patient was given fluids, as well as 2 units of packed red cells for her anemia, and 4-factor PCC was given to the patient. She then stabilized and was admitted to the ICU for endoscopy.